Okay, so I think we'll begin. Welcome everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special program, a collaboration between the Blum Center and Heart Center's Corrigan Women's Heart Health Program. Before we begin, just wanted to go over a couple of items with you all. Please note that today's session is being recorded for educational purposes. If you'd like to view the recording of today's session, you can visit our Blum Center website at massgeneral.org/Blum-Center. Please note everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions, please ask your questions using the chat feature, which is located at the bottom of your screen. We'll have time for them at the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical questions or information in the chat box. If you have a personal medical question, please ask your doctor. All right, Dr. Honigberg, would you like to pull up your slides?
Absolutely.
All right, so next, I would like to introduce you all to Dr. Michael Honigberg. He is a cardiologist at MGH affiliated with the MGH Cardiovascular Disease Prevention Center in Corrigan Women's Heart Health Program, as well as an instructor of medicine at Harvard Medical School. He is also a scientist whose research focuses on sex-specific risk factors for heart disease in women and on improving preventive cardiovascular care for everyone. In observance of American Heart Month, as well as Go Red for Women, which is today in support for women's heart health, Dr. Honigberg joins us to give a presentation on sex differences in heart disease and unique risk factors in women. So please join me in welcoming Dr. Honigberg.
Thanks so much. Can you see my slides okay?
Yes.
All right, fantastic. Thanks so much to all of you for spending your lunch hour with us today. As Amy said, my name is Mike Honigberg. I'm a cardiologist here at MGH. I'm a researcher affiliated with the Broad Institute of Harvard and MIT, where much of my research focuses on sex-specific risk factors for heart disease in women. I know as part of this session today, we have a variety of folks in the audience, from patients and non-medical folks to clinicians to researchers and investigators. So I've tried to make this sort of accessible and interesting to all levels. But I would say if anything comes up that is sort of too technical or is unclear, please feel free to ask for clarification. I'm happy to explain further. As Amy said, I'll be talking about some sex differences in cardiovascular disease that we think are important. But I'll really spend a lot of time focusing on some of the unique risk factors for cardiovascular disease that are specific to women and that we focus a lot of our research efforts on. A good portion of my research is funded by the National Institutes of Health. I have no industry or commercial relationships. By way of a little bit of brief background before we jump in today, since this talk really focuses on sex and gender differences, there sometimes can be some confusion about what exactly these terms mean, and so I don't want there to be any such confusion. So strictly speaking, when we refer to sex differences, we're referring to innate biological differences that are related to the sex chromosomes themselves and downstream biological effects. So women have two X chromosomes, men have an X and a Y chromosome. This leads to differences in sex hormone levels and gene expression. And so sex differences, strictly speaking, refer to those sorts of things. Gender differences, by contrast, refer to how human beings interact with the environment around them. So gender differences refer to differences related to environmental, social, or cultural factors related to being male or female. For example, differential childcare responsibilities have historically fallen upon, women in our society. In research and in day-to-day life, it's often somewhat difficult to clearly and cleanly distinguish what are sex effects versus gender effects. And so we sort of lump them together when we can't say for certain which is at play. So here, for the purposes of this talk, I'll be using sex as a shorthand for both sex and gender. I'll start by reviewing some key sex differences in common forms of heart disease. This could be like a 3-hour talk in itself, so this won't be exhaustive. This will just hit some of the more common conditions that we see in our clinical practice. We'll then spend some time talking about two key sex-specific risk factors for heart disease in women, and that's adverse pregnancy outcomes or pregnancy complications and early age of menopause. I'll talk a little bit about what all of this means for prevention of heart disease in women, both women who don't have established heart disease, as well as risk reduction in those who do have heart disease, and close with a little bit on hormone therapy and heart disease risks, since this is another area of some controversy in the last 20 years, and also an important area of women's heart health. So starting with sex differences in heart disease, if there's nothing else that we want to emphasize on American Heart Association Go Red for Women Day, it's that cardiovascular disease is the #1 killer of both men and women in the US and also around the globe. Cardiovascular disease is responsible for 1 in 3 deaths of US women. To give a little bit of context for some of the heart conditions we'll be talking today, I want to do a very, very brief anatomy review for folks. On the left, have a sort of a picture of the human heart from the outside, and displaying the coronary arteries are blood vessels that supply oxygenated blood to the heart muscle. They travel along the outside of the heart, and then they dive in and branch to supply blood to the muscle. So when there's disease of the coronary arteries, we refer to that as, there are multiple different terms for that disease, which can be sometimes confusing, but we can call it coronary artery disease, coronary heart disease, ischemic heart disease. Those are all terms referring to disease of the coronary arteries. Moving to the picture on the right side, we have a picture of the human heart in cross section, sort of sliced through the middle, to see some other structures. So the heart has 4 valves that ensure that blood travels forward in the correct direction and doesn't leak backwards in the wrong direction. You can see 3 of the valves in this picture fairly clearly, and then there's a 4th one hiding a little bit here. When the disease of the heart valves develops, we call that valvular heart disease. And then finally, what you can see here is the heart muscle. And the heart muscle can become diseased in a couple of ways. It can become stiff and unable to fill properly. It can become weak and dilated. Both of those problems can lead to something called heart failure, or also known as cardiomyopathy. And then there are other aspects of the heart as well that aren't well seen in these drawings, including the electrical conduction system, which we won't have time to talk about today. The most common form of heart disease in the US and worldwide is coronary artery disease. Coronary artery disease is a bit of an umbrella term that encompasses both heart attacks, which is a sudden problem of the heart arteries, leading to heart muscle damage and chest pain, as well as conditions that cause gradual narrowing of the arteries and chronic chest pain. Coronary artery disease can be caused by multiple different processes, but by far the most common is a process called atherosclerosis, which is where cholesterol plaque deposits in the wall of the heart artery, as shown here on the right side. These cholesterol plaques can break open suddenly, causing sudden blockage of the artery, leading to what we classically refer to as a heart attack. Or, as I mentioned, they can narrow slowly over time and cause chronic insufficient blood flow, so as not to cause a heart attack, but as to be symptomatic and cause chest pain. There are numerous well-described, well-established risk factors for developing atherosclerosis of the coronary arteries. These include high blood pressure, high cholesterol, smoking, being overweight or obese, diabetes, among others. And several of these risk factors seem to be more strongly linked to the development of coronary artery disease in women as compared to men. Specifically, these are smoking, obesity, and diabetes. All of these increase coronary artery disease risk to a greater extent in women as compared to men. I'll focus a little bit on blood pressure here because there's some really interesting sex differences in blood pressure and in normal vascular physiology across the lifespan between men and women. On the left, I'm displaying average systolic blood pressure in men and women. And we can see that in early life, women on average tend to have lower systolic blood pressure. So that's the top number when a blood pressure is measured compared to men. But you also see that as women get older, so age is displayed on this horizontal axis here, the slope of their blood pressure trajectory increases to a greater extent. Blood pressure increases with age in everybody, but it appears to increase more steeply and more rapidly in women as compared to men. Part of the explanation for this might relate to what we see on the right-hand side. I've depicted here something known as artery stiffness, or for the clinicians and researchers in the group, this is actually, strictly speaking, pulse pressure, so the difference between the top and bottom number when you measure a blood pressure. And similarly, this number accelerates more rapidly in women over the life course compared to men. We still don't fully understand why this happens. This is an area of active research and investigation. Some of it may have to do with hormonal effects across the life course, and some of it may be actually like a physics and mechanical issue related to smaller blood vessel caliber in women as compared to men. Regardless though, blood pressure is an important risk factor for heart disease in both men and in women. We know that on average, not all the time, but on average, women who develop coronary artery disease are 7 to 10 years older than men who develop coronary artery disease. However, having said that, heart attacks can and do still occur in much younger women. When they occur in younger women, they are more likely to be missed, or then there's more likely to be a delay in diagnosis. And in much younger women, heart attacks are often caused by conditions other than atherosclerosis, so other than those cholesterol plaques that I displayed just a few slides ago. Some potential causes of heart attack in younger women include a phenomenon called spontaneous coronary artery dissection. Mass General is a center of excellence for the treatment of this condition. What this is essentially a tear or blood clot develops in the blood vessel lining or the blood vessel wall in the heart arteries, and it has a similar effect of causing insufficient blood flow through that artery and chest pain. These spontaneous coronary artery dissections can be caused in some individuals by a genetic predisposition to collagen vascular abnormalities, conditions such as Marfan syndrome or Loeys-Dietz syndrome, fibromuscular dysplasia. Spontaneous coronary artery dissection is substantially more common in women as compared to men. Fortunately, this condition often heals with time, and patients can go back to living normal, active lives. Another condition that is actually not a coronary problem, but can present very similarly to coronary artery disease is something called Takatsubo Syndrome or Takatsubo cardiomyopathy, which is sometimes colloquially referred to as broken heart syndrome because it often occurs after periods of intense emotional stress. This is a condition where there's sudden stunning of the heart muscle. It's also an incompletely understood condition, and we don't fully understand why this happens and why some people are more susceptible. But when this condition occurs, an area of the heart, usually the front of the heart, which is this area I'm tracing here with my mouse, becomes stunned and doesn't squeeze normally, whereas the back portion of the heart shown here does continue to squeeze normally. And this can present with chest pain, like a regular heart attack, and also can cause elevated heart muscle enzymes in the blood, like a regular heart attack. Similar to spontaneous coronary artery dissection, this condition typically resolves in individuals and the prognosis is typically quite good. Another condition related to the heart arteries that doesn't present as a heart attack, but does cause chest pain is something called coronary microvascular dysfunction. This is a condition of chest pain where there is no significant blockage of the large coronary arteries that run along the outside of the heart surface, the coronary arteries that are typically involved in garden variety run-of-the-mill heart attacks and coronary disease, but rather involve disease of the microvasculature. So our coronary arteries branch and then they branch again and they give off these very tiny vessels that dive into the heart muscle. And it's dysfunction at this level of the coronary artery that is microvascular dysfunction. And this can cause chest pain and can be misdiagnosed and missed for a long time because we look at someone's coronary arteries and we don't see blockages that explain their symptoms, and it can sometimes be a disorder of the microvasculature. This condition is also much more common in women as compared to men, can be frequently misdiagnosed, or there can be a delay to diagnosis. And so it's an important consideration when we have a patient with concerning sounding chest pain, but normal stress testing or normal evaluation of the coronary arteries this is a consideration in those patients. When patients come in with a heart attack, with a sudden blockage of a coronary artery, I want to emphasize this point because this has been sort of misunderstood in the lay press in recent years. Chest pain and chest pressure are the most common presenting symptoms of a heart attack in both men and women. It was previously reported, in the press that women more commonly had other symptoms. Which isn't strictly speaking true. However, they are more likely to display a broader range of presenting symptoms and often multiple symptoms simultaneously. So they're more likely to also come in with symptoms like shortness of breath, nausea, arm discomfort, abdominal pain, back pain, instead of or in addition to their chest pain. And so that we really want to drive home that if you know your body, and if there's something that's wrong, that it could be one of these sort of fake out symptoms or another symptom that could represent a heart attack, it's important not to write it off. It's important to get it evaluated on the sooner side. It's not uncommon that we see patients who sit home with symptoms that they think are indigestion or acid reflux, when in fact it's a heart problem. So important to sort of talk to a doctor or seek evaluation, in a timely fashion if that's a consideration. When it comes to treatment of coronary artery disease, we know there are large sex disparities in sort of the adequacy of treatment, as defined by our guidelines that say what optimal treatment of these conditions look like. We know that women compared to men are less likely to be prescribed and to take some of these key heart medications, things like aspirin and related blood thinners, statin and related cholesterol lowering drugs, and other medications like beta blockers, as well as medications for blood pressure. Moving on now from coronary disease to heart failure. Heart failure, again, this is a condition where the heart's pumping is inadequate to keep up with the body's demands. And there's really two main flavors of this that we encounter in our clinical practice. There's heart failure with preserved ejection fraction, which can sort of be thought of as stiff heart muscle. The heart muscle squeezes, the heart muscle is strong, but it doesn't relax normally. And so the heart can't fill with blood normally. And this makes it difficult for the heart to keep up with the body's needs. This condition, heart failure with preserved ejection fraction, or a stiff heart muscle phenotype, if you will, of heart failure is much more commonly seen in women. By contrast, men are more likely to develop weak heart muscle, heart failure with reduced ejection fraction. And this distinction is important because it dramatically determines how we treat each type of heart failure. And in 2021, there are currently many more effective therapies for heart failure with reduced ejection fraction than there are for heart failure with preserved ejection fraction. And so understanding the reasons that this condition develops, as well as new targeted treatments for heart failure with preserved ejection fraction, is an active area of investigation here and around the world. So I'll transition now to talk a little bit about some of the sex-specific risk factors for heart disease in women. You might be surprised to hear that pregnancy can be thought of as a window into a woman's long-term heart health. So we don't necessarily think of pregnancy as a particularly high-risk time for heart disease in the immediate or in the short term, but we do think of it as a window into long-term risk. So there are several conditions that have now been linked to future increased risk of heart disease. These include the hypertensive disorders of pregnancy, which include preeclampsia, which you might have heard of, used to be known as toxemia, gestational hypertension, which is essentially a slightly milder version of preeclampsia, eclampsia, which is preeclampsia with seizures, and HELP syndrome, which is a version of preeclampsia associated with liver and blood test abnormalities. I would summarize all of these conditions as being characterized by new or worsening high blood pressure in pregnancy, often but not always associated with the leakage or the wasting of protein in the urine in a way that's abnormal. So that's a set of conditions that have been linked to future heart risks. Another one is gestational diabetes. And the third is preterm birth, which we define as birth occurring before 37 weeks gestation. And the long-term heart risks appear to be particularly great when preterm birth occurs even earlier, like before 34 weeks gestation. And together, these conditions have all been linked to roughly a doubling in the later life risk of coronary artery disease, as well as the risk of stroke. I'll focus a little bit about some of our research here on the hypertensive disorders of pregnancy. I'll also add that this is a surprisingly common condition among pregnant women. I think the commonness of this condition has been under-recognized until recently, but we know now from recent data that 7.5% of women in the US experience preeclampsia at least once in their reproductive history, and 15% experience some version of a hypertensive disorder of pregnancy at least once. So these are not rare conditions among women. We've, through our research, using a large cohort based in the United Kingdom, we've discovered that the hypertensive disorders of pregnancy are linked essentially to accelerated aging of the cardiovascular system, with increased risks of coronary artery disease, as mentioned, also of developing heart failure, and then as well developing valvular heart disease, both of the aortic valve as well as of the mitral valve. Why does this happen? This is an area of ongoing active investigation that we are very actively pursuing. I will say what we know at this point is that development of chronic high blood pressure after pregnancy appears to explain a decent portion, although not all, of the excess future heart risk seen in women with a history of a hypertensive disorder of pregnancy. There also appears to be a shared genetic risk, we've learned, between preeclampsia and the other hypertensive disorders of pregnancy and future cardiometabolic and heart risks. So we know that a genetic predisposition to high blood pressure, as well as a genetic predisposition to higher body mass index or to obesity, is linked to both preeclampsia as well as future heart disease risks. There's also some observational data suggesting that among women who have a pregnancy complication like a hypertensive disorder of pregnancy, returning to pre-pregnancy body weight and maintaining a normal body weight may prevent or at least substantially delay the future development of chronic high blood pressure. So this may be one particularly important area to target for long-term risk reduction in this population of women. I'll talk a little bit now about menopause. Menopause, as this group will know, is the cessation of the menstrual periods caused by depletion of ovarian follicles, in sort of late midlife. We know that earlier age of menopause is associated with an increased risk of cardiovascular disease, both coronary heart disease as well as stroke. So age of menopause is displayed on the horizontal axis here, and as age of menopause gets earlier and earlier, risks progressively increase. The average age of menopause in sort of the US and Europe, sort of Western countries, is about 51 years of age, and risks seem to start to increase progressively with any menopause earlier than that, although the risks don't get large until really early age of menopause. We in our group have done work looking at conditions beyond coronary heart disease and stroke, as well as menopause that's caused spontaneously or sort of natural premature menopause, as well as menopause that's induced surgically due to surgical removal of the ovaries for any one of a variety of reasons. And we see that for not just coronary artery disease, but also for valvular heart disease like aortic stenosis, as well as for arrhythmias like atrial fibrillation, the risks progressively increase with earlier age of menopause, and they appear to be stronger or sort of greater in women who have surgical menopause as compared to spontaneous menopause. One hypothesis is that this is driven by an abrupt decline in sex hormones in women who experience surgical menopause, whereas women who experience natural or spontaneous menopause have a more gradual decline in sex hormone levels. But the truth is we still don't really know. And that's another area of ongoing active investigation. One potential related cause could be that traditional cardiovascular disease, heart risk, cardiometabolic risk factors develop faster in women who have earlier menopause. So here I'm showing in this cohort that we've done all this research in, again, based in the United Kingdom, that the development of high blood pressure, high cholesterol, and type 2 diabetes appears to be accelerated in women with a history of premature menopause, here defined as occurring before age 40, with especially higher risks observed in women with surgical as compared to natural or spontaneous premature menopause. I'll talk a little bit now about what all of this might mean for the prevention of heart disease in women. Before we get to that, though, I just want to take a step back and summarize, particularly for the patients who are joining us, how we as cardiologists and other types of physicians as well, primary care doctors, endocrinologists, kidney specialists, how we all assess a patient's heart disease risk, particularly in individuals who have not yet developed heart disease. There are this sort of standard, well-established list of risk factors that I alluded to earlier in the talk: age, sex, race and ethnicity, specifically Black and South Asian race and ancestry, are known to be linked to increased risk of heart disease. And those aren't really modifiable risk factors. You know, you can't do anything about your age, sex, or race. Those are determined for you. Some of the other risk factors, though, are modifiable. And those include your blood pressure, your cholesterol levels, whether or not you have diabetes, and use of tobacco products. We take all of these variables and we either formally or informally incorporate them into a score, and we assess whether an individual's risk of developing heart disease in both the sort of intermediate and long term is high, borderline or intermediate, or low. And we use these classifications to guide how we counsel patients how they can best reduce their risk of developing future heart disease. For individuals where, just based on this short list of risk factors, where the calculated or projected risk is high, we recommend a combination of lifestyle modification as well as medications to reduce risk. Most commonly statin medications, which work by lowering cholesterol, sometimes aspirin as well, depending on the individual, although we're prescribing that less these days. For folks who fall into the low risk category, we say, you don't need additional medications, but we recommend lifestyle modification for everybody to keep their risk low over the course of their lifetime. So lifestyle modification means things like keeping a heart healthy diet, ensuring adequate aerobic exercise, and maintaining a normal body weight. For folks in the intermediate bucket, we recommend lifestyle modification to everybody, and then we typically have a discussion about whether they might benefit from additional medication as well. And we often, the intermediate risk bucket is actually a pretty big bucket with a lot of gray area. And so this is where we in our current practice, we often incorporate other risk factors into our calculus and into our counseling. So what are some of those other risk factors that we might consider? This is where family history can be very important, because a family history of early heart disease in particular can be a clue to underlying genetic risk that might be inherited across families. The presence of something called metabolic syndrome, which is where individuals tend to have higher body weight that's concentrated sort of centrally on the trunk and on the torso. These folks tend to have a high level of a type of cholesterol called triglycerides, and low levels of what we think of as the good, quote unquote, good cholesterol, HDL, or high density lipoprotein cholesterol. They tend to have either pre-diabetes or diabetes and higher blood pressure. And all of this together, we know portends an increased risk of heart disease. Kidney disease is another sort of additive risk factor for developing heart disease. A less commonly measured type of cholesterol called lipoprotein A, when it's high, can be a sort of additive risk factor beyond our traditional risk factors. elevated systemic levels of inflammation, which can be measured through a laboratory test called C-reactive protein, and relatedly autoimmune conditions, which are more commonly seen in women, are also linked to higher risk of heart disease. And then there's our truly sex-specific risk factors for heart disease that we just talked about, a history of pregnancy complications, including preeclampsia, preterm birth, and gestational diabetes, as well as premature age of menopause, which our guidelines define as occurring before age 40, but which we know risks go up, with even less severely early age of menopause before age 45 or before age 50. So we think about these risk enhancing factors most of all when we're thinking about statin prescribing decisions. So for individuals who fall into that intermediate risk bucket that I was talking about, we say, is there something else that should push us to recommend a cholesterol lowering therapy to decrease their heart risk? And so the presence of either of these sex-specific risk factors in women, either a complicated pregnancy or an adverse pregnancy outcome or premature menopause, according to our current guidelines, suggests that there's benefit from recommending and starting statin therapy for what we call primary prevention, which is to say for the prevention of the development of any heart disease in the first place. So for the patients who are participating today, that's sort of a lot of very complicated information. Perhaps helpful to just sort of summarize in simple terms, how can I reduce my heart risk today? And this actually also applies to folks with established heart disease as well. How do I reduce my risk of having future heart events in addition? Things we recommend to everybody include a heart healthy diet. We get a lot of questions these days about specific types of diets. And I can say the two varieties of diet that are really supported by rigorous science and by randomized controlled trials are the Mediterranean diet and the DASH diet. The Mediterranean diet is, and there's a lot of similarities between these diets, I should say. They both emphasize large portions of fresh produce, specifically vegetables, fresh fruit, which we know Americans do not eat in adequate quantities by and large. They both encourage, particularly the DASH diet encourages moderation and reduction in dietary salt intake with the goal of really keeping blood pressure low. The Mediterranean diet also to a slightly less strict extent. The Mediterranean diet emphasizes incorporation of healthy fats. So that's, say, fats found in fish. The oil in fish is very high in healthy fat. The fat that's found in, say, tree nuts like almonds and walnuts, avocado, olive oil in particular, is high in healthy fats. So emphasizing those healthy fats while avoiding the unhealthy fats, specifically saturated fats, which red meat, for example, is very high in, trans fats. These are the diets that really we know are linked to improved heart health. We get a lot of questions. I'll just sort of riff a little bit and say we get a lot of questions about the keto diet these days as a way to facilitate sort of easier weight loss and potentially improved blood sugar control. And I would say there is as well as time restricted eating, we get a lot of questions about that as well. And I would say there are many different ways to do both the keto diet and time restricted eating. If you do the keto diet and time restricted eating with burgers and eggs, that's not heart healthy, even if it's very low in carbohydrates. Whereas diet versions of those diets that are very high in plants content, high in fresh vegetables could actually be very healthy. But not all keto diets are the same, and not all keto diets we know are not all of them are heart healthy. So it's both sort of how much and really equally, if not more so, the quality of what you're eating. Something else we recommend for all of our patients is exercise with an emphasis on aerobic exercise. The American Heart Association recommends at least 150 minutes a week, so that's 2.5 hours a week, of moderate intensity or greater activity. So, a lot of folks, get some of their exercise by walking, and that's great. And avoiding sitting, avoiding being sedentary is huge. But it's even a step better if you can really get your heart rate up and break a sweat. And so I tell my patients, I think of moderate intensity activity as activity that's strenuous enough that you can't have a full conversation while doing it. You want to be out of breath. You can't speak in complete sentences. And that's really a better, more heart healthy way to exercise if you can do it. And it's obviously harder in New England in the midst of a pandemic, but sort of home stationary biking, ellipticals, treadmills, or putting on your snow boots and going for a brisk walk outside, all that would count. So that's all very important. Maintaining a normal weight obviously relates to the two items above this, both dietary intake and exercise. And in some ways it's obvious, and in some ways it's not. But in order to lose weight, you have to burn more calories than you take in, and it's sort of as simple as that. In terms of substances, we very strongly encourage our patients to not smoke any tobacco products, and there's mounting data that marijuana use is also not heart healthy. It might be a little bit less injurious to the lungs, but it's certainly not heart healthy. And so we recommend avoiding smoking all products like that. Excessive quantities of alcohol intake are also separately associated with increased heart risks. And so current guidelines recommend no more than 14 quantities of alcohol per week per men and 7 per week for women. And the actually healthy amounts might actually be a little less than that. Certainly, we recommend moderation of those things. I think this is probably not a problem for the folks joining this call, but for a broader population, routine medical care can be hard. And you want to be getting routine medical care throughout the life course, at all ages, with routine age-appropriate screening for heart risk factors, including high blood pressure, high cholesterol, and diabetes. As we discussed, depending on your level of risk and your risk factors, preventive medications such as statin medications, sometimes aspirin may be appropriate depending on your particular condition. And then I think for Go Red Day, and particularly with respect to this talk, something that we see a lot is that women's physicians don't actually know their pregnancy and their menopause histories. Particularly obstetrical care can sometimes be fragmented from later life primary care. And so just making sure that particularly if there's any history of pregnancy complication and any history of early menopause, that your doctor knows that, because that information is often not known, that can be missed. So I'll transition to the last part of the talk, which is focused on hormone therapy, another female-specific cardiovascular consideration. I'll start with a very brief history of hormone therapy. It was first introduced in clinical practice for the treatment of menopausal symptoms, which specifically hot flashes and night sweats, in 1942, when it was first recognized that supplementing estrogen could mitigate these symptoms. However, about 30 years later, we realized that when we give estrogen alone, that increases the risk of endometrial cancer in women who still have a uterus intact. So the way that we counter that risk of endometrial cancer is by adding progesterone to the hormone preparation. And so starting in the mid-1970s, hormone replacement therapy became combination with both estrogen and progesterone. Similarly, there was a recognition of breast cancer risk seen in the late 1970s in women taking exogenous hormone replacement therapy. However, there was also mounting data suggesting that there were other health benefits of hormone replacement as well. There was suggestion that hormone replacement was protective for the heart and blood vessels, as well as protective for the bones against fracture, and protective to the brain in terms of memory and cognition. And so in the late 1990s, you had review articles like this being published in the prestigious New England Journal of Medicine, extolling the various protective effects of estrogen on the cardiovascular system. But importantly, these data were based on observational studies, which can be subject to limitations. But with this mounting observational data in hand, prescribing rates of hormone replacement skyrocketed through the 80s and the 1990s. And then we started getting our randomized controlled trials. So in the late 1990s, the HERS study was published. This study examined women who had established coronary artery disease, and it was a randomized trial that randomized these women to receive combination hormone replacement or a placebo. And the trial study staff were shocked really to observe that despite hormone replacement making the cholesterol levels look better, it was also associated with an increase in adverse coronary artery disease events at 1 year. And that after 4 years, there was essentially no positive effect or negative effect on average observed in the study population. Meanwhile, it increased the risk of developing blood clots in the legs and the lungs, and it increased the risk of developing gallbladder disease. I will say that the field was very surprised by this result and didn't quite know what to make of it at the time. And then came the Women's Health Initiative, or WHI, which was sort of the next big and sort of the seminal study looking at the effects of hormone replacement in women. And this trial was actually stopped early due to an adverse safety signal and due to a concern that hormone replacement was actually causing harm in the population studied. So this was a population of postmenopausal women who now, in contrast to the HER study, this population did not have any established or known cardiovascular disease. Again, they were randomized to either combination hormone therapy if women had a uterus, or to estrogen alone if they had had a prior hysterectomy. And again, there was seen sort of multiple signals for harm in this population, including an increased risk of coronary artery disease, breast cancer, stroke, and blood clots in the lungs, also known as pulmonary embolism. And so after these two trials, there was a dramatic decline in prescribing of hormone therapy seen in the US and also worldwide. We've learned a little bit more nuances about the effects of hormone therapy since the initial publication of these trials. And I think importantly, the degree to which hormone therapy increases a woman's risk depends heavily on how old she is at the time of initiating hormone therapy and how far or how long it's been since menopause. And this is kind of a complicated table from the study, but I'm just going to focus you on this line of results, where women in the study are broken out into 3 categories of how far out they are from menopause. And you can see that the risk, the HR is basically stands for hazard ratio, and that's the risk associated with receiving hormone therapy. And it goes from being perhaps protective among women closer to the age of menopause to more and more harmful. The greater the number is above 1, the more we're worried about harm. And so it's really in women who are 20 or more years out from menopause that we become most worried about the risks. And so we now incorporate these data, and this has been shown in other studies too now. We incorporate this data when we're sort of assessing risk and benefit of using hormone therapy, because for some women, menopausal symptoms can be debilitating, and hormone therapy is still the most effective way to treat those symptoms. So what do we recommend? So for women who have moderate to severe hot flashes, night sweats, and other, we call them vasomotor symptoms of menopause, if they're younger than 60 years old and within 10 years of menopause, and they don't have any conditions that make them very high risk, like a history of blood clots, then we say it's okay to proceed using hormone therapy, and we recommend using the lowest dose that effectively treats symptoms and using it for the shortest possible duration, which means sort of continually reassessing how the symptoms are and potentially trying to lower the dose over time. There's also society recommendations to formally estimate a woman's coronary artery disease risk before she receives a prescription for hormone replacement therapy. If the 10-year risk using our standard risk calculators is between 5 and 10%, the guidelines, or there are other sort of active risk factors like established high blood pressure or a woman is an active smoker, then the guidelines recommend using estrogen patches instead of pills, which we think are a little bit safer from a heart disease standpoint, or using non-hormonal therapies to treat the symptoms. Things like serotonin reuptake inhibitors and clonidine can be alternatives to hormone replacement for treatment of night sweats and hot flashes. And then we say if a woman's projected 10-year risk is over 10%, then we say hormone replacement probably isn't the safest for her. And that's where we really say it's important to consider non-hormonal therapies. Another recommendation based on the trial data is that if a woman has had a hysterectomy, meaning removal of the uterus, the heart risks seem more favorable with estrogen alone as compared to combination hormone therapy with both estrogen and progesterone together. Finally, as alluded to earlier on the slide, continual reassessment of menopausal symptoms is important, with the goal of at least starting to taper within 3 to 5 years and avoidance of continuing therapy beyond age 60 or 65, particularly if a woman has increased heart disease risks. So the summary of this somewhat complicated slide is, the pendulum has swung on this, but it's not that hormone therapy isn't safe for anyone. It's that there are some women where it's less safe, and it seems to be women who are really older than 60 and further out from the age of menopause. So just to summarize some of the many things we've talked about today, we've talked about some key sex differences in common forms of heart disease, as well as forms of heart disease that are more common in women. We've talked about how adverse pregnancy outcomes like preeclampsia, as well as earlier age of menopause, are sex-specific risk factors for heart disease that are unique to women. We've talked about how anyone, but particularly women, can maximize their heart health over the life course, which I think includes ensuring that their doctor knows their reproductive history, including any pregnancy complications, as well as age and mechanism of menopause. And finally, we talked a little bit about hormone therapy, who it's safe for, who it might not be as safe for, and how we assess risk prior to prescribing. Thank you all so much for your attention. Thanks for participating today, and I welcome any of your questions.
Thank you so much, Dr. Honigberg, for a very helpful presentation. So now we are going to open up the session to questions and answers. So if you have a question for Dr. Honigberg, please use the chat box and ask your question. So Dr. Honigberg, we have a few questions in the chat box already. Let's see, we have first question being, you had mentioned that women with coronary artery disease are less likely to take medications like statins. Is there a known reason for this? For example, are they prescribed to women less often?
It's a super good question. I think it's an area where we actually incompletely understand the reasons. Part of it, though, is differences in prescribing. Women with coronary artery disease are less likely than men to be prescribed the medications in the first place, but that doesn't fully explain the gap that we observe between women and men. So it's possible that we don't know this for sure still. This is an area of evolving science. It's possible. One potential explanation is that women are more likely to have side effects or not tolerate some of our standard heart medications. And so I think moving forward, we have to be really thoughtful and study potentially alternative strategies or different dosing that sort of minimize these side effects and make these medications easier to take for our patients. But it's a really good question, and it seems to be probably a multitude of factors that are not just differences in prescribing rates.
Thank you. We have another question. Can you explain the role of poor sleep in elevating risk for heart disease? How much do we know on this link? If someone has had a history of poor sleep, but then improves their sleep quality time after 30 years, will it make a change in their risk profile for cardiovascular risk?
That is an outstanding question. Well, we haven't talked about sleep during this. Poor sleep, it is a risk factor for cardiovascular disease, and we think that's independent or separate from these other things. We know that very short durations of sleep, inadequate sleep, definitely increases risk, and that probably relates to things like stress hormones and the neurobiology of sleep, which may basically provoke a pro-inflammatory response in the body. With respect to very long sleep, it's sort of a U-shaped curve. So very short duration of sleep and also very long duration of sleep are both associated with increased cardiovascular disease risk. Long duration of sleep, I think we understand a little bit less well, may relate to just like less time being active and more time being sedentary. Very long periods of sleep is also linked to depression, which may be related to other sort of adverse health behaviors and taking less good care of oneself. So definitely an independent risk factor for bad cardiovascular outcomes. Another potential cause of poor sleep that we know is strongly linked to poor cardiovascular health is obstructive sleep apnea, which is a very common and underdiagnosed cause of poor sleep in the population. For individuals who have sleep apnea, the use of positive pressure at night, CPAP, continuous positive airway pressure, can have a host of positive cardiovascular benefits, including improving blood pressure, improving sleep quality and duration. Weight loss and alcohol moderation can also greatly improve sleep apnea in individuals who have it. And so there's definitely strong multiple interlinkages between sleep quality and cardiovascular health, and would certainly encourage anybody to take what, to work with their doctors to improve the quality and quantity of their sleep, not just for cardiovascular health, but for overall sort of mood and overall health and happiness.
Thank you. Next question. What do the findings of age differences and effects of hormone therapy imply for people taking hormonal birth control or a young transgender woman on hormonal replacement therapy? Does the long-term duration of those medications pose more risk, or is the young age protective?
Such a great question, and it's actually remarkable. We understand the long-term cardiovascular risks of oral contraception less well than we understand the risks associated with hormone therapy. We know, in general, we know that oral birth control, oral contraceptives are quite safe for the vast majority of women. In general, we recommend using the lowest effective dose for any particular woman, particularly if there's pre-existing high blood pressure, which can sometimes be exacerbated by certain preparations of oral contraceptives. There also can be idiosyncratic or sometimes unpredictable, I should say, effects of birth control on cholesterol levels. For many women, there might be mild beneficial effects on observed cholesterol levels, but that's not true across the board. And I sometimes get referred women with very high cholesterol levels taking birth control, and when we temporarily withhold their birth control, their cholesterol levels get much better. We don't understand why some women respond that way and some don't. But it's not sort of uniform across the board how each individual woman will respond to birth control. So I think it's a great question for which we have sort of complicated and incomplete understanding at this point. But I think there definitely is warranted a discussion with the prescriber if there are pre-existing risk factors already established in a premenopausal woman still taking birth control. So if she has high blood pressure, you might want to think about alternative birth control mechanisms. Intrauterine devices such as the Mirena IUD are extremely safe from a cardiovascular standpoint and tend to be our go-to recommendation for birth control in the population of premenopausal women with established cardiovascular disease or at very high risk for early cardiovascular disease. So we recommend women have that discussion with either their primary care physician or their OBGYN, early if we're worried about their heart risks. The transgender population is a fascinating population from the standpoint, a dramatically understudied population where much, much, much more research is needed. In general, we think that it's probably that the risks associated with exogenous hormones are probably safer in trans women, which is to say individuals who are born biologically male who transition to being women, as compared to the opposite direction in terms of trans men, where it's individuals who are born female and transition to being male. It would appear, there can be adverse effects of exogenous hormones in both directions. Although from a cardiometabolic standpoint, we think that exogenous testosterone is probably a little bit riskier than exogenous estrogen. That's not to say there aren't risks associated with exogenous estrogen in this population as well. We do think there's probably an increased risk of blood clots, for example, in the legs with exogenous estrogen. So it's always sort of a risk-benefit discussion based on an individual's risk profile who's undergoing such a transition. And having an endocrinologist involved or a sort of expert in transgender health can be extremely important for that population.
Thank you. Next question. What do you recommend for a postmenopausal woman with very low blood pressure? Are there implications of heart-related issues related to very low blood pressure?
It's an excellent question. In general, on average, blood pressure increases after the menopausal transition. So if you're a woman who has persistently low blood pressure after menopause, kudos you, because you're an outlier. And whether we worry about someone's blood pressure being low really depends on whether they're symptomatic from their low blood pressure. If you have asymptomatic low blood pressure, that's actually fantastic because that's actually protective against long-term heart disease. If you're symptomatic from your low blood pressure, then we want to do some more investigation to figure out why that's the case, because that wouldn't be normal necessarily. But certainly if somebody has asymptomatic low blood pressure, that generally is actually favorable for long-term heart health.
Thank you. We have time for one more last question. If your HDL is very high and LDL and triglycerides are within range, hence your overall cholesterol score is above 200, is that heart protective?
So that's a really good question. It probably is to a point. There are some syndromes where the HDL cholesterol is extremely high, where that sort of the trend of HDL being associated with a protective effect seems to reverse. But just sort of mildly elevated high HDL is probably favorable. I would encourage individuals, though, we sometimes anchor exclusively on the cholesterol values alone and neglect the entire constellation of potential risk factors. And so a normal cholesterol in range, sort of normal LDL cholesterol, normal triglycerides, doesn't necessarily get everybody off the hook when it comes to long-term heart health. And so important to be incorporating all of the other sort of known and identifiable risk factors as well. Things like blood pressure, smoking, diabetes, weight, exercise, diets, the pregnancy history factors we talked about, family history, and other things. So it's an important data point, but it's not the only data point.
Sure. So we're running out of time. Do you have time for one more last question? Okay. So you mentioned many risk factors and indicative symptoms specific to women regarding cardiovascular health that we now know exist. But how long has this knowledge been around? What are some interesting points in the history of cardiovascular treatments and diagnosis in women that you know of?
This is such a good question, and it could be like its own 2-hour talk. I mean, I would give the historical perspective that it was really less than a generation ago that we still thought of cardiovascular disease as a man's disease. That's the genesis of Go Red for Women Day. That's why this month and today exist. Because we've just learned so much over the last generation, really, about women's heart health. There are many points I could emphasize. I guess I'll focus on, I'll say 3 things briefly, really trying to emphasize diseases that where we're much more in our infancy of understanding them than we are in terms of our understanding of heart disease that's caused by cholesterol plaques. So atherosclerosis we understand pretty well at this point, but it's the other non-atherosclerotic processes that we're still in the early stages of fully understanding. So things like spontaneous coronary artery dissection. Melissa Wood here at MGH is an international leader in this and has really sort of led the field in our understanding of this condition, why it happens, how we optimally treat it. It's a condition that we've probably missed throughout history. When you look at the pictures of these women's coronary arteries, the way that we typically do it in the catheterization lab, if you're not thinking about this diagnosis, you often miss it even when it's there. And so by raising awareness of conditions like spontaneous coronary artery dissection, we're now finding it a lot more where it was previously missed. And so, that creates opportunities for us to study it, to understand it better, to develop better ways to predict it, to prevent it, and to treat it. That's one example. Another one would be heart failure with preserved ejection fraction, the sort of stiff heart flavor of heart failure that I described earlier. It's a condition that wasn't even really recognized until the early, or didn't sort of get its own diagnosis until the 2000s. It was also previously largely unrecognized, and it's much more common in women. So it's another one where we're doing the research now to sort of catch up and understand how do we predict it and prevent it. Jennifer Ho here is a sort of international leader in that effort. And so that's another area. And then I think another big one as we head into the next decade is the coronary microvascular dysfunction or microvascular ischemia, where I showed the picture of the coronary microvasculature and the branching coronary arteries. We didn't used to be able to diagnose this. And so individuals, particularly women, would present with concerning chest pain that sounded cardiac. We would do what used to be our standard testing and tell them they were fine, that they were anxious, that it was all in their heads, when in fact it wasn't. It's a real condition, and we have some treatments that are largely effective for it. I wouldn't say perfect, but that's another one where there's tons of research still to be done understanding why exactly it develops, how we optimally prevent it, how we optimally treat it. So I think long answer to a really good question where it's that we are still in early days, honestly, of fully elucidating and understanding these conditions that we now know are more common in women as compared to men.
Thank you so much, Dr. Honigberg, for a wonderful presentation. And thank you everyone for joining us today. We hope you found today's session helpful. As I mentioned, if you're interested in viewing a recording of today's session, I've given about 2 weeks, but it'll be available on our Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a good day.
Thank you.